Chapter 16 will cover general pharmacology. We're going to talk about the medications that an EMT can administer. Typical medications found on the ambulance is aspirin, oral glucose, oxygen, and activated charcoal. Aspirin is given to patients with suspected cardiac-related chest pain. The aspirin acts as a platelet aggregate. What that means is a lot of times in a heart attack there is a clot in the heart. So that platelet aggregate keeps the clot from getting any worse. A lot of people think aspirin's a blood thinner, but it just kind of stops the clotting process. So in the act of a heart attack, when you give them aspirin, basically all the platelets get covered up in a lube and they won't stick together anymore. It's not going to bust up the clot that's already in there, but just prevent that clot from getting any bigger. Give oral glucose to the patient with hypoglycemia, the patient with low blood sugar. This is basically just straight sugar that is flavored. Oxygen, covered that multiple times, given to a patient who is hypoxic or just needs to maintain oxygen levels. Activated charcoal, something that's not seen as nearly as often anymore. It's given to patients with suspected poisoning, such as the person who wanted to kill themselves by taking a whole bottle of aspirin. It's a very nasty substance. It's black and looks just like liquid charcoal. Prescribed medications of the patient that the EMT can assist administering. An inhaler, or a puffer as they call it, nitroglycerin, or an EpiPen. The puffer, I believe a lot of people are familiar with these. For the person having shortness of breath, the asthmatic, the COPD may have these, and the EMT can assist in giving these. It acts as a bronchodilator. They take in a deep breath, the bronchioles will dilate, open up, allowing them to get a better breath in. Generally given for patients who are wheezing, because they've got those narrowed bronchial passages. So the bronchodilator will dilate the bronchioles. Nitroglycerin, given to the patient also for chest pain. It comes in a couple of different versions, either a spray or a tablet. It dilates the coronary vessels, so that patient experiencing that chest pain, and referring back to anatomy lab, talking about the preload into the heart. So the blood return going back into the heart, it'll open up those vessels, reduce the preload, help reduce the damage caused by possibly the hypoperfused heart, and will help reduce that pain going to the heart. A contraindication for nitro is a patient already has low blood pressure, because as it dilates the coronary vessels, the blood pressure will drop. So if the patient already has low blood pressure, generally less than 100 of a systolic pressure, or if they're taking any male enhancement supplements such as Viagra, Levitra, Cialis, or similar. And actually all of those medications, just for little fun facts, were intended to be a blood pressure medicine. When they gave initially Viagra to patients to help control their blood pressure, they started realizing it was enhancing male genitalia. So if they are on any of those medications, taking any of those, depending on protocols, within the last anywhere from 24 to 72 hours, depending on which enhancement it was, they can't take any nitro or their blood pressure will plummet very quick. The Epi Auto-Injector. This is prescribed to patients who have anaphylactic reactions. Those patients who have anaphylaxis to, say, bees, shellfish, things of that nature that causes them to have life-threatening reactions. The Epi Auto-Injector, it acts as a bronchodilator, acts on the beta receptors, which opens up the airway, and acts as a vasoconstrictor, acting on the alpha receptors. Now remember, alpha and beta, alpha 1, beta 2. Alpha 1, you got one heart, so alpha deals with the heart. Beta 2, you have two lungs. So beta acts on the lungs. So you administer the auto-injector by essentially stabbing them in a big, thick, fatty part of their body and hold it for 10 seconds. The epinephrine releases and causes a bronchodilation, allows them to breathe easier, and will constrict those vessels because as a good anaphylactic reaction, the bronchioles constrict and their vessels dilate. So the Epi Auto-Injector reverses that. Some other medications that can be administered is Naloxone, also known as Narcan. This is for the patient who is suspected as overdosing on narcotics. And you're giving this to patients who are in respiratory arrest or complete respiratory failure due to taking the narcotics such as heroin, overdosing on fentanyl, and these are those patients who are apneic, pinpoint pupils, or any patient who's just altered, unresponsive, is suspected of being overdosing on narcotics. There is no true side effects to this, so it's kind of given as a prophylactic for the unresponsive patient anymore. It can be given as a shot in the IV or sprayed up their nose. And also the Atropine auto-injector. This is used in some places for threat of biological warfare, just the big doomsday things that whenever those terrorists want to react. Some places carry atropine auto-injectors that you can stab each other with to save your life. Also, Albuterol. Same medicine that's in the inhalers, an EMT can administer it as a nebulizer set. A epinephrine injection, same as the auto-injector Epi, except that EMT can give it as a shot intramuscularly. Now all the medicines discussed, EMTs can give, and depending on certain areas, whether they can give it off the ambulance or assist a patient in it. In West Virginia's standpoint, all of these medications can be given by the EMT off the ambulance. So here's a chart of the medications that an EMT can give. Albuterol is 2.5 milligrams in a 3 milliliter solution. You should be able to repeat that verbatim by the end of class. 2.5 milligrams in a 3 milliliter solution. That's given nebulized, whether through the puffer or through the nebulizer set, which hooks the oxygen, creates a mist, and it's inhaled. That's given as needed. PRN is a term you'll hear. That just means as needed. Contraindications for albuterol is tachycardia, since a side effect of that is tachycardia, and it also causes jitters and shakes. Aspirin is 324 milligrams. That's 4 baby aspirin, 4 81 milligram tablets. That's given PO orally. That's just chewable aspirin. That's why in the ambulance it's carried as baby aspirin, because you don't have to have anything to drink it down with. It's just chewable. And you give that just one time. A contraindication for that is any kind of bleeding, since that is a platelet aggregate. If clotting does need to happen, they don't need to be having aspirin. And a side effect of that is just poor taste. Epinephrine, given as that auto-injector or given as a shot of 0.3 milligrams. It's given IM, intramuscularly, as needed. A contraindication for that is if the person's not in anaphylactic shock. So if they're not having major hives, difficulty in breathing, altered mental status, hypotension, if they just have some hives and itching, they do not need epinephrine, as it will cause tachycardia and hypertension. That's the same medication paramedics give dead people, trying to bring them back to life. So just imagine how invasive that is on somebody who's already alive. Naloxone, Narcan, given anywhere from 0.4 to 2 milligrams, can be given intramuscularly or intranasally. So you can give them a shot or sprayed up their nose. And that's also given as needed. So contraindication for that is if they don't have difficulty in breathing, if they're not in respiratory arrest, or have an altered mental status, they don't need Narcan. Side effects of that is combativeness. If they're given too much, that brings them completely back from death to being wide awake and their high is reversed that fast, they will become combative. Also with that, they can become nauseous and vomiting. They will have projectile vomiting, kind of like you see in the exorcism movies. They will come back from the dead and just projectile vomit all over the back of the ambulance. Nitroglycerin, 0.4 milligram tablet, giving sublingually. That's just under the tongue. Just hold it under the tongue till it dissolves. That's given every 3 to 5 minutes for a total dose of 3. So a contraindication for that is a patient taking male enhancements, or if they are hypotensive, a systolic blood pressure less than 100, seeing as how it will also cause hypotension. Also, it will cause a headache or give them a sour taste in their mouth. Oral glucose, anywhere from 15 to 25 gram tubes, given just PO, so it can be put in the patient's cheek just to kind of let them slowly dissolve it, or just given orally just for them to basically straight eat it, and given just as needed. Contraindication is if they are hyperglycemic. If their blood sugar is high, they do not need any more sugar in their body. So the side effect can cause hyperglycemia. Now, giving a patient just tubes of oral glucose is a slow process, and it's not going to take their blood sugar from 50 to 400. It's a very slow process and will just increase it slightly. Oxygen, 2 to 15 liters per minute, depending if it's on a nasal cannula or an on a breather. That's inhaled and given as needed. Generally, there's no contraindications or side effects of it. You just have to be cautious with pediatrics and those COPD patients, or the ones who operate in a normal hypoxic state. But that hypoxic state to be disturbed is over a very long period of time. Some general information about medications. Each drug is listed by a generic name. Each drug also has at least 3 names: its chemical name, its generic name, and its brand name. For example, for what we know as Tylenol, the trade name of Tylenol, its generic name is acetaminophen, and there is its chemical name of N,4-hydroxyphenyl acetamide. So what you need to know about when you're going to give a medication. You need to know what the indications are for it. So why does the patient need it? What indicates the patient needs this medication? A contraindication of why don't they need it? A side effect, just knowing what will happen, and the untoward effects, what you don't want to happen. So for instance, the patient having chest pain. Chest pain is the indication of it. A contraindication to give it is if that patient having chest pain took a Viagra tablet the night before. A side effect is what you'll need to explain to the patient. So if they start to feel a weird kind of way, they will know that that is to be expected. And the untoward effects is you don't want the patient's blood pressure to suddenly drop and they go unresponsive. So the medications come in multiple forms: compressed powders or tablets. Say nitroglycerin comes in a tablet. Liquids, the nitro spray can be in a liquid. Gels, like your oral glucose, a suspension, that activated charcoal, a fine powder, which some other ones can come in that is gases, oxygen, and the sublingual sprays also, as the nitroglycerin is in that spray. And back to the liquids is epinephrine, albuterol. Multiple things can come in liquids. So if you've ever been a person who's ever taken any kind of medication, you've probably seen them in every one of those forms. Medication authorization of when you can or cannot give medications. 2 basic terms: offline medical direction. That means you have standing orders on it. You don't have to call medical command and get permission. Whereas online medical direction means you have to call medical command, get permission to do it. So whenever you call and get orders to do that, you must repeat it back. So if medical command says you may give nitroglycerin 0.4 milligrams every 3 to 5 minutes for a total dose of 3, you would repeat back and say, that's received nitroglycerin 0.4 milligrams every 3 to 5 minutes for a total dose of 3. And if there's any weird questions you have about it, or if you believe they told you wrong, ask for clarification. When giving the medication, you need to know the 5 rights. Do you have the right patient? Is it the right time? Is it the right medication, the right dose, and the right route? So knowing, is it the right patient? And that ties into if you are giving or assisting a patient with their medications, are you giving Mrs. Smith a medication that has her name on it, or does it have her husband's name on it? If it does not have the patient's name on it, you cannot assist giving that medication. Is it the right time? If the medication, say with nitroglycerin, if it has to be given every 3 to 5 minutes, knowing, are you in the right time frame? And is it the right medication? Reading the labels. A lot of medications come in very similar packaging, so you need to ensure you're giving the right medication. And is it the right dose? Say for epinephrine, when you've drawn it up, are you giving the right amount of it? Are you giving 4 baby aspirin instead of 3? Making sure you're giving them the exact right dose and the right route. Making sure you're giving them the medication as they should. And all that can tie in because routes may change the dose for the patient. Speaking of routes, there are numerous ways to administer medications. So some acronyms that tie in with those. Oral or swallowed, PO. Sublingually, just dissolved under the tongue, sublingually. Inhaled, used as an aerosol spray, those puffers, or a gas that is nebulized. Intranasally, sprayed right into the nose, IN. Intravenous, right into the vein, IV. A shot given right into the muscles, IM. Subcutaneous, just injected slightly under the skin, SQ. Intraosseous, injected into the bone, IO. Endotracheal, medicine given in the ET tube of the intubated patient, is ET. Now, numerous of those, ET, IO, IV, those are performed by paramedics only, but it's good to know just those routes. There are some age and weight related considerations. Sometimes a patient must weigh a certain amount to be able to receive a certain dose. Also, every medicine affects every patient differently. So think, for instance, higher on that a patient who's on pain medicines every day may need a higher dose of pain medicines when they are in a whole lot of pain. So thinking about all the pharmacodynamics of everything, that's just knowing everything involved with medicine, its side effects, its contraindications, everything. Just how will this affect your patient? What do you think is going to happen to that patient when you give them the medication? After you give a medication, you must reassess them. For one, to see that they are improving, which is what you're hoping for, or if there are those untoward effects of the patient getting worse. So for instance, you give a patient nitroglycerin, yes, their chest pain may go away, but now they may be unresponsive because their blood pressure dropped too quickly. And you need to clearly document everything that you've done. So writing down the times of everything that you've done, just so then that way you can remember if it's been so long you need to give another dose, you know what time the last dose was at. So some medications that patients often take. These are going to be common types of medicines you'll see that a patient's going to give you, or you'll see on their medication list. Just a good rule of thumb, some good stuff to know. If a drug ends in O-law, that's a heart pill. As the patients will always say, I take my heart pill. If it ends in O-law, that is a beta blocker. That is used for treating hypertension. Plavix, a common type of blood thinner, very good to know for that trauma patient. Lipitor, Zocor, Crestor, taken for high cholesterol. Good to know if you see a patient telling you that, or you see it on their list for the patient having chest pains. High cholesterol ties right in to cardiac disease. Advair, asthma. You see it on a list, they have breathing problems. Metformin, for the diabetic, that's a pill form, where so many people are infamous knowing insulin when they take the shot. Diabetics can also take the pill. Amoxicillin is a very strong antibiotic. Hydrochlorothiazide, a very common hypertension pill. And acetaminophen, hydrocodone, a pain pill. One of the most commonly abused drugs is that. That is your Percocets, things of that nature. Assisting in IV therapy. EMTs can help paramedics set up their IV fluids. It's actually a very big, important role of the EMT to speed up patient care. So the fluids and medications can be given through the IV bag. Traditional setups, just an IV bag hanging above the patient, where fluid will continue to flow down through a tube straight into the IV or even to the IO. Setting it up, the IV bag is just a clear plastic tubing connected to the fluid bag, which goes to the catheter. The catheter being the part that stays in the vein of the patient. The true IV is a catheter. There's three basic parts of it. The drip chamber, where you see the fluid dripping out of the bag into the little chamber, drip chamber. The flow regulator, a little turn wheel, so it'll help you regulate how fast it's going to drip or how fast the fluids are going to flow. And the drug or needle port. On the bottom of the bag, there is an access port to where if any medications need to be given into the fluid bag, or if some fluid needs to be brought out of the bag, they can access that port. The extension set just makes it easier to have that longer tube from the fluid bag so the patient can move around, the EMS folks can move around, you can get the clothes off, everything of that nature. So setting up the IV bag, be sure to take a look at it, make sure that everything's in date, that right patient, right route, right time, your main 5 R's, making sure that it's in date, it's clear, it just doesn't look nasty, making sure that it's actually the same type of fluid, because multiple types of medications come in a clear bag. You'll take the safe cap off of the needle of the drip chamber, and then the needle of the drip chamber will go into the port of the IV bag. The IV bag will have a safe sterile guard on that too, generally just a little blue rubber cap that'll just be pulled off, and then the needle is poked into it. You'll then make sure that the flow regulator is closed and just squeeze on the drip chamber and fill it about halfway full. Once that's done, you'll open the flow regulator to allow all the fluid and all the air to drain out of the tube, because bubbles into a vein are very bad. Once you've drained out all the bubbles and it's only fluid in that clear plastic tubing, turn off the flow regulator. To maintain the IV, you may have to troubleshoot it every once in a while. Whenever the paramedic puts on the tourniquet to start the IV, if that's still in place, the fluid's not going to flow. Also, if issues with the flow, checking the flow regulator, making sure the tubing isn't clamped or kinked, or the line could be pinched, say under a backboard, and the causes any kind of error that could cause the fluid to not flow properly. And always keep an eye on when that IV site is there to make sure you don't see any edema coming around the IV site. That means the fluid is going into the muscular space instead of into the vein.